My name is Fadi Fakhouri. I'm professor of nephrology, previously in France and currently in Lausanne, Switzerland, in a university hospital. I have been working for more than 20 years on complex-mediated disease, kidney disease mostly, and I coined the term C3 glomerulopathy more than 16 years ago. I was involved not only in basic research, but also in clinical trials with all the new drugs that are emerging for complement-mediated disease, particularly C3 glomerulopathy. It's a rare disease, but it's a very severe disease that affects equally children and young adults. It may occur in older people, sometimes associated to monoclonal gammopathy, but it affects mainly children, young adults with very severe outcome. The signs are not very specific. They are common to all glomerular disease, including regular checkup showing proteinuria, hematuria, high blood pressure, for example. More rarely, gross macroscopic hematuria, blood in the urine that you can see easily. But it's very severe disease because up to 2 years ago, we didn't have any specific treatment, and more than 50% of these patients, a lot of them young patients, if not children, reach end-stage kidney disease and require dialysis and kidney transplantation. And on top of this, there was a high risk of recurrence in the kidney transplant, almost 80%. 80% maybe it's an exaggerated figure, but at least 50%, and leading to the loss of the kidney function of kidney transplant in a significant proportion of patients. So it was a double negative impact on quality of life for these patients, usually young, in native kidneys, and even after kidney transplantation. Up to 2 years, they were managed in very conservative way. As you know, C3 glomerulopathy arises from deposition in the kidney, in the glomerulus, of C3. C3 is a component of complement system. C3 degradation product produced in excess and that deposit in the kidney, creating the disease. So up to 2 years, we didn't have any tool to remove this deposit. All we could do is reduce blood pressure, reduce proteinuria with non-specific drugs. And in some cases, we used to use mycophenolate mofetil and corticosteroid just to clear a little bit inflammation. But all these therapeutic approaches didn't have any impact on the driver of the disease. So up to 2-3 years, they were managed in very conservative ways that did not change radically the very bad outcome of these usually young patients. Pegcetacoplan is a compound that binds to C3 and C3b and thus prevents the degradation of C3, which means it targets the main driver of the disease by preventing C3 degradation product deposition in the kidney. So it goes right away to the main problem in C3 glomerulopathy. It is given subcut twice a week with a very good tolerance, and it was tested in a controlled prospective study, which is not very frequent in glomerular disease because they are rare. VALIANT study was, as I said, a prospective randomized trial, a design that we should more and more frequently use in rare kidney disease because it provides definite proof of the efficacy or non-efficacy potentially of a drug. So patients with C3G and immune complex MPGN, a very close and similar disease, were randomized 1-to-1 to receive pegcetacoplan or placebo for 6 months. Placebo was not main placebo. It was placebo on top of maximal standard of care, which combined antiproteinic drug and MMF and corticosteroid in more than 80% of patients. So there was not just placebo. It was on top of optimal, at least maximal tolerated doses of current standard of care. And at 6 months, it was judged based on evolution of proteinuria, eGFR, but also in terms of reduction of C3 deposit in a rebiopsy. And after 6 months, all the placebo group were switched to pegcetacoplan group for 6 additional months. And at 1 year, all patients went into an extension open label phase of the trial called VALE that will give us long-term outcome of patients treated with pegcetacoplan for C3G and immune complex MPGN. The results were very impressive already at 6 months. So let's start with 6 months. At 6 months, you had 68% reduction in proteinuria on top of maximal antiproteinuric drug and on top of MMF and corticosteroid. A very impressive results, rarely if hardly ever seen in glomerular disease. 68% reduction compared to placebo. And on top of this, 71% of patients on rebiopsy cleared all their C3 deposits, something not previously seen in C3G patients. We never could clear their C3 deposits. Now we see it in more than almost a quarter of the patient. And already at 6 months, you had stabilization of eGFR and a dramatic decrease in eGFR decline in the pegcetacoplan treated group compared to the placebo. And at 6 months, there was a gain of more than 6-7 milliliter per minute eGFR in the pegcetacoplan compared to the control group. So at 6 months, it was already impressive. And now we have data when we switched patients from placebo to pegcetacoplan, and pegcetacoplan continued to receive pegcetacoplan for 6 additional months. So in the placebo group, you had the same dramatic decrease in proteinuria, starting as early as 1 month, continuing up to 6 months. And at the end, they had a very significant decrease in proteinuria after switch from placebo to pegcetacoplan, and around 55, 67, 65%, maybe a little bit less than the peg-to-peg group, because they lost 6 months in a very severe forms of the disease. And at the end, you have a rather stabilization and a clear slowing of the progression of decline in eGFR. At 1 year, we had confirmation of the very excellent results we had at 6 months in the pegcetacoplan group, and we had also the proof that switching patient from placebo to pegcetacoplan, we have the same impressive results on proteinuria and clearance of C3 deposits. There was no biopsy mandatory at 1 year. So biopsy is only at 6 months, but the overall effect of proteinuria and already in GFR is very important, because we know that proteinuria is a very good surrogate marker for long-term outcome in these patients. And we know that reduction of 50% proteinuria in this patient makes a lot of difference in the long term in terms of preservation of kidney function. So very good news for patients and for clinicians. For the community, I will start with the community because it's more important than physician. Community, finally we have a drug that is effective, disease-specific, that not only decreases proteinuria by a massive 70% more or less, but also clears the primary driver of disease, which is C3 deposit. So we have the tool to reverse even the pathological features of the disease in the kidney. So very good news, and we will see in real life, and I'm quite confident that real life data will confirm this excellent data in the randomized trial. So very good news for the community and thus for physicians. They have finally a drug that is not only cosmetic or conservative or a standard of care just reducing proteinuria. We have a drug that is treating the problem at the root. The other good news for patient and physician is that we had a previous study called Noble study, and now we have a small subgroup of patients who were kidney transplant with recurrence of the disease. And now we have the evidence that pegcetacoplan also is a very efficient drug to treat recurrence of C3G in the kidney transplant, which means we can now salvage native kidneys, but for those unfortunately who reach end-stage kidney disease and require transplantation, they can go for transplantation, potentially even with living donation, which was a little bit contraindicated due to the high risk of recurrence before pegcetacoplan. So now we can go in a more confident way to kidney transplantation because we have a very powerful drug to treat a potential recurrence in the kidney graft.